It is my great pleasure and honor to be here today, and I thank all of you to be here. And I was surprised to see fully booked the workshop on Saturday, 1 o'clock, reasonable weather, beautiful Vienna, last day. And I will try to satisfy the expectation, trying to show you my experience and my ideas, and the experts' ideas, motivated from guidelines, reported in papers, but showing in the daily practice how to use the tips and tricks to obtain what is called the warranted or the tailored examinations. Firstly, we start from thyroid. Then I will talk about salivary glands, and I will also give you some feedbacks on lymph nodes, because we are doing a very nice prospective studies to try to cover what is still considered the Achilles tendons in our diagnostic imaging. I usually start to do a research when I have some doubts, some questions to be answered. So I look at the literature and I see what is present, what is still missing. At that time when we started, we understood that still we need something more to address the possibility to reduce the number of unnecessary biopsy and the unnecessary thyroidectomy. How to do it? Which are the new tools that we can use in daily practice to try to overcome this kind of limitations? Firstly, epidemiology. We know that the number of pulpal nodules is increasing every year. Several factors behind. Another factor is due to the fact that we are every day scanned by ultrasound for different reasons, and incidental findings are very common. We have to take into account that in general, the majority of thyroid nodules are benign. However, also the incidence of the malignant ones is increasing. But then at the end of the day, we have to ask, what is the real outcome of these patients? How many of them really needed to be treated soon, and how to choose the right surgery or the minimally invasive treatment as well? What we usually do, first imaging modality is ultrasound, color Doppler ultrasound. It is very effective to depict also lesions that are smaller than 1 centimeter. We are detecting sub-millimeter lesion right now. But this is also a problem, because unfortunately, to characterize those very small, tiny lesions is very complicated. Usually, what we have to report, the presence or absence of lesions, we have to describe where they are located, the number of them, the dimensions, and then provide the echo structures. Echo structure may be solid, may be liquid, may be mixed. And then within it, we have to provide hyper-iso-hypoechogenicity. And then we have to describe the contour, the limits. Because the borders, if they are infiltrated, they are worrisome. If not, it could be a benign sign. But I will show you what is the sensitivity and the specificity of the single signs. Then we have to describe what is considered not a worrisome sign, but a benign sign, the peripheral halo. But also, if you depict a peripheral halo, you need to be very precise to describe, because sometimes it can be asymmetric, and this is a worrisome sign. Then we describe the distribution. If the lesion show a vertical growth, this means that it's going against the nature, because in general, gravity helps to create the increasement of the dimension on the horizontal plane. If it happens in the vertical plane, it was already described and proved in breast, but right now is also considered a worrisome sign for papillary carcinoma, which is the majority of the malignant nodules. And then vascularization. In the 90s, everyone started to use color Doppler, and everyone, starting from the Folkman assumption, what is neovascularized could be considered worrisome. If they look at the nodule and found vascularized nodule, they stated this should be submitted to fine needle aspiration. I was one of the first who claimed about that sign, because I found in my experience, probably because also at that time I had very good equipment, but I found that at that time 60% of benign nodules were highly vascularized. and only 70% of malignant show the same appearance. So it was like throwing up a coin, and then let's see what is the results. Right now, color Doppler is not included in any kind of thyroids. About thyroids, we will talk later. Therefore, let's look at single, different, specific findings. We know that the presence of microcalcification could be considered worrisome. The presence of markedly hypoechogenicity. How can you really be sure that it's markedly hypoechogenicity? You have to compare with the muscle. If it is lower than muscle, it is markedly hypoechogenicity. If it is similar to muscle, it is mildly hypoechogenicity. So, remind, this is objective, subjective evaluation. Secondly, microcalcification, hypoechogenicity, margins. Of course, we are doing 2D examination. I will show you, with this new machine, you can do the 2D, 3D examination. Same probe, only one sweep, and then you obtain really the representation of the vascularization and of the entire volume of the nodule that helps you to better define. And then, of course, taller than wide. But if you look at sensitivity and specificity, if you have a sign who has high sensitivity, conversely, it shows low specificity. And at the end, the good friend of mine, Rago and Vitti, and you will see that we published recently, the guidelines of all the society together concluded that unfortunately, no signs, no single ultrasound sign is enough accurate to make the diagnosis. Therefore, we tried to mutuate what was already established for breast. From BIRADS, we started to use TIRADS. Unfortunately, to now, we have 9 TIRADS. Not universally used. Why? And I would like to ask you, how many of you use TIRADS? Okay, 15, 20% over 80, 90 is not bad. In general, the number is lower. But which TIRADS are you using? European?
The original, the first one.
So, the Horvat? Yours? Yeah. So, European. Okay. I will show you some results about the comparison between them, but still there is much confusion. So we need to go through it. According to the presence of the literature, to now, the most used is the K-WAC, the QUAC. But, and according to it, we suggested to use TIRADS. However, look at the consensus, 57%. 60% of the experts were in favor of TIRADS, 40 were against. Why? Horvat. It was proved that there was higher interobserver variability compared with the elastography. Other reason behind. Here I summarized all the different available TIRADS, and if you look, the difference are not so high. They describe from 3 to 5 class of risk, the K-TIRADS. And then if we review some cases together, it would be interesting to understand how do you classify the lesion. For instance, this one, according to QUAC, is 3, is mixed deletion. How do you rate? Follow-up. So benign.
And there is, yeah, and there is another thing. What is the history of the patient? It's no only.
Okay, it's true, it's true. Yeah, but yeah, okay, yes, of course, it is firstly based on lab analysis. Follow-up. Okay, so benign, still benign. This one starts to be solid. According to QUAC, is 4A. According to Kappa, is 4. According to other, is 3. So now we're starting to have some confusion. This one, okay, it starts to be worrisome. Not yet. It does not say that. It say not. Was papillary carcinoma.
The other one.
Yeah, the other one. That's strange. I know. Unfortunately, and I will show you the results, also using TIRADS. This one and this one, taller, microcalcification, fairly marginated, hypoechogenicity. Okay. What we did the review retrospectively with all the endocrinologist group in my university. I have the luck that I have a very good endocrinologist. One of them published 3 papers in JAMA, one in New England Journal, and now is really, really the one who is followed to understand the natural history of the nodule. Because what is important is to understand, if I follow up this patient, this nodule, how much does it increase in size? And then, if it increases in size, how much of the number of those nodules will be malignant or benign? So what we did, we compared the different thyroids. Because still too many biopsy, so we need to find a way to reduce the number of biopsy. Then, unfortunately, inter-observer variability, time-consuming, and confusion. We found at the end of the results that the American one was quite better in sensitivity, but not in specificity. And the others, the K thyroids and the others, were very similar. If you look at this table, sorry, here are all the different thyroids. Here are the numbers. You will see that are very, very similar. And the European and the ACSA has better sensitivity, but look at specificity, dramatically low. This is how do they summarize the different also possibility to decide according to the size, according to the score, which one is the nodule that should be submitted or not to fine needle aspiration. At the end, we know that we really work on it to find a way to reduce the inter-observer variability, to reduce the consistency, the time consuming. Therefore, we started also to look at different classification, different society recommendation, which one are the one that should be submitted to fine needle aspiration. Also in that case, there is no universal consensus. And if you look at fine needle aspiration, how many of them are really effective? 10% first try can give false negative results. Can be reduced, but still it is a non-invasive, but still invasive procedure, and cost. Therefore, we started to use something new. We know by the ancient Egypt, and it is due to Hippocrates, that we included palpation as part of physical examination of our patient. However, we know also that digital palpation is subjective and limited. Depends on the patient, depends on your experience, depends on where the lesion is located. MRI was the first imaging modality to include the study with elastography. However, the results are not yet very well established. It works for prostate, it works for liver, it works for brain, but still is not included in the daily life. And the software are expensive and not widespread used. Therefore, ultrasound field started to use this kind of new software, the elastosonography. It helps us to show tissue stiffness or deformability rather than anatomy. And combining the two information, we try to have another additional value of our examination. We have to divide two different types of elastography. The strain, or so-called quasi-static, means that you can palpate through the probe the nodule, and then you make compression, or you may use the pulsatility coming from carotid artery, and then you achieve the deformability of the nodule, and according to it, there will be a colorization of the entire field, polychromatic map representation, qualitative, subjective evaluation. Then you put two ROI, one within the nodule, another one on the corresponding, at same level, thyroid parenchyma, and then you have the strain ratio. Semi-quantitative evaluation. Soon after was introduced ShareWave. ShareWave uses a push pulse that can give a transmission of the waves, and the waves transmitting, depending on how much hard is the nodule, they will be transmitted and deflected higher or lower with the speed and elasticity that can be measured. And with this technique, we can have quantitative evaluation. And to now, we already start to say, this is the best one. Let's discuss about it, and I will show you what is the evidence to now of all the experts. Firstly, when we start to do something, and when we need to convince patients, and firstly, ourselves to do something, we need to remember what Claude Bernard was used to say in his introduction of the study of experimental. Experimental medicine is nothing more than a reasoning by means of which the ideas undergo onto the control of facts. What we need to have robust data coming from multi-center studies, or we need evidence-based guidelines. We were lucky to have the possibility to work together, radiologists, non-radiologists, under EFSUM umbrella, and we did publish several guidelines in different fields, CUS and now Elasto. These are the two that we firstly published in Ultrasound. Good news, you can just Google EFSUM website and you can upload for free. As editor of Ultrasound, I'm pushing on Ultrasound to make more educational paper for free for everybody. Secondly, WFUMB, that is the World Federation, also published personal own guidelines. I was one of the few of EFSUM involved also in thyroid and prostate guidelines, and we publish in Ultrasound Medicine Biology. Not good news, these are not for free, so you have to pay, unfortunately. Ultrasound Medicine Biology still does not allow. How does it work? You press, and then you have this representation. Okay. Or you just press a button, there is a transmission of the waves, and the waves arrives here, and here you have a specific, unique feature provided by this machine. You have the propagation wave. So you can see real time, parallelly with all the other images, baseline, share wave, plus on kilopascal or meter per second, and then you can really see how do the waves propagate. And according to it, I would like to remind to all of you to find the right protocol to obtain better results. And I will show you how to do. Firstly, let's start with strain elastography. What is strain? Strain means deformability. If a body is compressed, may deformate according to the stiffness. If it is more stiff, it deformates less. If it is soft, it deformates more. But what is the results that we can achieve with this machine? We can see the polychromatic representation. First element to take in mind, the polychromatic representation could be changed, could be different in any equipment that you use, and you can change it. It's like color Doppler, red or blue. It depends on you. It depends on how you decide to change your equipment. Secondly, we started and we found that was too much subjective because we were not able to have an indicator of quality compression that helped us in real time to be sure that we were doing properly or not. Afterwards, Canon, also thanking our strict cooperation, decided to provide you this kind of real-time waveform-shaped qualitative indicator that can help you. Could you press on the video, please? So what is important is we have to do this firm, precise, vertical compression. You have to use the color box in the right way, including a part upwards and a part downwards, including the lesion and the thyroid. Then you look at your polychromatic map, and then you can continue with your examination. Some tips and tricks. Box. How big? I told you. Secondly, look also for the presence of some artifacts. If there are artifacts, repeat. Third, look at the polychromatic map representation. Then look at quality control indicator. If it is really fitting with the scheme, the rectangle should be fulfilled with yellow or completely or part of it. Now you can do the step forward. You can put ROI, one within the lesion, another one within the thyroid, avoiding the artifacts, and then you look at the number. So this is what you should do every day with strain. After that, now you have to look at the results. This is the classification that I'm using in daily life, the modified Rubaltelli classification published in Ultrasound, based on Ueno Ito that was referring to breast. After that, there were the specific one for thyroid. Score 1 means that the lesion is completely soft. 100% yellow, green, according to the scale that you are using. Meanwhile, conversely, the score 4 should be completely unelastic. But now we have to put in the daily life. This is some prerequisite. Let's see with some example. First case, the lesion is completely soft. Second case, the lesion is almost completely soft, but still there are some stiff areas, less than 25%. Now we are entering in the gray zone. 3A, 3B, less than 50% is 3A, more than 50% is 3B. Most probably, if I ask you, we could divide each other to say 3A or 3B. 3B, mostly unelastic, still with some soft areas. And then finally, the last one, the lesion that is completely, totally unelastic. And I will show you later a detail that it is important to predict the worrisome disease from not worrisome disease. After the first evaluation with qualitative polychromatic representation, you may do the strain ratio. We were one of the first group to publish about this new technique. What was important at that time, no cutoff values were available. And unfortunately, this is still the Achilles tendon of this technique. Any machine has a different cutoff. And the cutoff, unfortunately, is not a fixed cutoff. So should be personally evaluated. With this machine, usually, now there is a consensus of all the experts that 2 plus less 0.5 could be the cutoff value. So this is what I do. The best B-mode image. Then you do elasto. Then you do the evaluation with the strain ratio. And then you compare, of course, with the cytology or histology. This was a benign lesion. This was the worrisome one that I showed you. Look, completely blue. Then we put 2 ROI. Look at the number. Number is very high, 7. But what is also important to underline? The size. If a lesion, after the strain elastography, increases in size compared with the baseline, this is a worrisome sign. It was reported for breast, but there are 3-4 papers right now in literature that are confirming, and also my pathology are confirming that when I told them, you know, it was 8 millimeter, after elasto is 1 centimeter, this is a worrisome sign. And also Richard Barr and other experts agree about it. So this is what usually I report. This is a lesion, I describe the lesion, I describe strain elastography, and then share where I will show you later, and then I conclude with my assumption. Again, just to remember, box, size, position, avoid artifacts, quality control, and then put the ROI in the right place with the right size. Some of you could ask me, how much big? Where should I put? Firstly, what is really important? Avoid artifacts. Secondly, you have to include the ROI within the lesion. And then you can have the corresponding size on the thyroid tissue. Of course, sometimes we don't have enough space. So we have to adjust. And this is the reason, because unfortunately, also in the expert hands, the results are no more than 90% of sensitivity. In the literature, a lot of papers, especially from China right now, most of them are confirming that this is a promising, established now, technique. Also, we try to understand what are the limitations. We published a special issue in European Journal of Radiology, and what was clear, remember carotid pulsatility, operator dependency, patient dependency, equipment dependency are the main reasons because you are not doing and you are not achieving the right results. Also, we published with Richard Barr a very good book that I suggest you to read because we included everything. But this is the first part. Now let's move on with something else. And something else is the new horizon, is the shear wave. When you throw a stone in the lake, you create the waveform. And this is what is happening when you push the button and then you start your examination. To now, there are 3 types recognized: the single point, the 2D, and the 3D shear wave. Again, the scheme I showed you, but what are the results? You can have the propagation mode, then you have the representation in kilopascal and meter per second. Of course, right now you can do in real time, all together, grouped together, to find the right results. Again, my suggestion, quality control, propagation mode. Where they are more parallel, put the ROI, avoiding artifacts, firstly. Secondly, look at the results, and then you give your report. Unfortunately, we know that cutoff value for shear wave is even more variable than strain elastography. Secondly, remember, not all the cancers in thyroid are stiff. 10% of them are soft. So the suggestion is to upgrade if a lesion is not worrisome at the baseline, but becomes worrisome at elasto, you can upgrade the score. Conversely, don't downgrade. Let's look at some recent case. How do you classify this case? Trials 3, 4, 5. Simple. Okay, benign or malignant? How many for benign? Nobody. How many for malignant? 1, 2, 3. Okay, the majority. So we started to do, we measure it to see if there is taller than wide or not. Then we put color Doppler, SMI, superior microvascular imaging, that is another innovation, and 3D SMI, that showed better that the lesion does not have any clear vascularization within it. So the statement, vascularized worrisome, is not really fitting with the reality. Let's look at elasto. How do you call this elasto? Worrisome or not? Worrisome. The number, 6. Shear wave, 5 meters per second. In general, with this machine, more than 4 meters per second, more than 50, from 45 to 60 is better. Okay, depends. If you want higher sensitivity, so it's better 60, 45. If you want higher specificity, 60. And then continuing, the 3D shear wave. This is another innovation that is very nicely showing you really the margin that were not clearly visible at baseline ultrasound. And final diagnosis, papillary carcinoma. Of course, you can use the 3D also with benign lesion, and also another feature, you can have a point in the center that can help you also for guiding in the future the biopsy. What about literature? Some meta-analysis showing and confirming that unfortunately still we have so many cutoff values. So shear wave is still not at the point in which we can use in the daily practice very useful. Elasto should be considered additional tool, should be used properly, should be avoided in a case in which is grossly calcified or with a cystic tensive area. Otherwise, you can achieve fast positive results. WUFUM confirmed strain elastography can be used. Still not recommended as should, but you will see at the end. Still not so many papers. And this is anticipation. This is under press in ultrasound. We group it together, and now we rewrite it, should be used. So we suggest to use Elasto as an additional tool. What about CUS? We were also one of the first group to show that it's better strain elastography than CUS. However, you can have qualitative, quantitative evaluation with CUS, especially in order to evaluate the treatment of those nodules. This could be useful. But according to our guidelines, we do not recommend in the clinical practice. Let's look at what we usually can do. This was a patient that was submitted to FNH and then was treated with alcoholization. Color Doppler, SMI, 3D SMI, look at the nice representation. Again, different planes, different possibility to show nicely the vascularization. Strain elastography, again, soft lesion. Shear wave, confirming that is really soft lesion. CUS showed the very similar appearance to the surrounding parenchyma. This is the subjective evaluation. As you can see now, the quality of a single bubble representation is very high. But this machine has another feature. You can have the polychromatic representation of the time arrival of the contrast agent. And if you see here, they have the same timing. And then you can put the ROI and you can compare. Conversely, could you click on this case, please? Worrisome lesion. Confirm that it was malignant. Look at the CUS. No vascularization. 30% of malignant nodules are non-vascularized. So we have to take in account. Have we done? Not yet. Have you had your lunch? Not yet. So you have to wait for eating. Because we have to ask us, SLE or shear wave, we need data. And now we have data. We just have this paper accepted on ultrasound, and we showed that strain ratio has higher sensitivity than shear wave, together can be combined to better provide a better specificity. We did this very long study, including a relatively good number of patients, and then at the end, we had the results. What we did classify with the KWAC. Of course, we can do with others. We will do it, we will try. We can also cooperate to use it, because we have data, so we can review the cases. And then at the end, we showed ROC analysis, strong statistics behind, because otherwise the results could be affected negatively. But let's look for some other cases. How do you call this case? Benign or malignant? Was tier 3B. So tier 3 means indeterminate at its cytology. B means more worrisome. Again, look at the protocol, look at the study, look at the quality of image, because otherwise you could achieve not good results. Again, different planes, again the representation. Strain elastography, very soft. Shear wave, with the new software that can help you to have really the grade of the representation, was quite higher. 425 was really in the gray zone, but then was benign. Again, another case, just to show you how also technology can help us to have a very nice image. And again, the consistency of the results between the methods, because at the end, we need to be consistent. Now, some worrisome cases. Let's look. What I'm using? MicroPure. MicroPure is specific software that can help us to depict only microcalcification. It is good for breast, good also for thyroid. Then again, we did the same protocol. We did the evaluation with 3D. Look at the representation. Most probably, we have to change the paradigm. We have to see if the presence of only few vessels, but irregular on the periphery, this could be very, very worrisome. We are trying to figure out if it is true or not. But with this software, we can do a try. Again, very nicely represented. Look at the number. Very stiff. Look at shear wave. Completely stiff. This one. 3, 4, 5, two nodules between, together. Looks like again, representation of 3D, and then, of course, again, how to put the row here. Okay, this is a case that I showed you because we have a representation of soft and hard tissue. I usually put in the center trying to have the most represented area. So mostly soft, so mostly should be soft represented. And then the number. And then look, shear wave was completely, in this case, very useful. Other case, taller than wide or not? Are you sure about it? Yeah? Look, it's easier also with the 3D reformatting. And then look at the number here. Very, 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 very not suspicious at strain, but more suspicious at shear wave. This was a malignant. Small lesion, so false negative at strain, true positive at shear wave. Small lesion, just to show you how can be very nicely represented also in very small lesion, 5 millimeter. You can do everything again, you can have good results again, and then you can confirm at the end the results. How do you classify this nodule? 4, calcification again, represented nicely. Look at the vascularization, very regularly represented. Low RI, sometimes RI could be considered suspicious or not. Again, stiff, and stiff at shear wave. And this was a medullary carcinoma. Plus, look at that, lymph nodes. Look at the representation, very similar to the nodule. What is important, when you have a doubt about a lymph node and you have already an established diagnosis, look for the same findings. If you found, you do a good diagnosis. Also with CT and MRI. Usually this is what I teach to students and residents. And this is really resembling. We also published the paper trying to put together the results of medullary carcinoma. Unfortunately, there is not clear consensus about how to describe medullary carcinoma. European Association, the EURADS, are recommending, not recommending, but suggesting to use elasto. We recently published also a new editorial. Unfortunately, there are still open debates. Strain or shear wave? I showed you strain, just better, yes, but according to the literature right now, strain has higher sensitivity, confirmed also by this very recent meta-analysis. Lymph nodes. What are the possibilities for lymph nodes? If you see this kind of lymph nodes, this is very reactive, very hyperplastic lymph node, very soft. Conversely, what could be this diagnosis? Okay, clinical scenario, you're right. Fever, intense fever. And this was a tuberculosis case, and I did this diagnosis only looking at it. Look at the vascularization. It looks like a caverna. So this is really the typical sign of a tuberculosis. Salivary glands, small organs, but at least in my university, we have one of the best surgeons, so we see 3-4 cases per day. What we need to know, 90% of the lesions in salivary glands, in major salivary glands, are benign. If you deal with the submandibular or even with the minor salivary, the rate changes. Is higher the rate of malignancy than the benign one. Then, this is the epidemiology behind, but what is important, risk factors. Ionizing radiation, we know that this is unfortunately one of the risk factors. That is explaining also the incidence. Between the malignant, acinic, and mucoepidermoid carcinoma are the most represented. Between the benign, Wharton, and pleomorphic adenoma, and mostly they are the majority. I summarized for you some important tools, male, female, age. When we do our examination, we take in consideration the anographic, the demographic data, and of course the risk factors. And then, when we start to imaging modality, we know that right now still fine needle aspiration is requested before surgery. unfortunately, also for fine needle aspiration, also for salivary glands, the results are contradictory. And we already published it. We are publishing a paper that we showed that they were lower as a sensitivity. Unbelievable. We changed at least 20 diagnoses from fine needle aspiration. You know why? Unfortunately, the new pathologies are not so much experienced. And that's the reason, that explains. Of course, now we can do MRI as a second level, and I showed you what is the diagnostic algorithm. So, diagnosis by clinical point of view, ultrasound, then we decide fine needle aspiration, MRI, but now we are using CUS and Elasto. We try to have a new hope. I like Star Wars, so I know that we have to look forward. Sometimes we come back, as Star Wars is doing. We start and then we come back to the previous, to the prequel. Again, Elasto, we have some guidelines, and we have also some papers. Also, these papers are downloadable for free. I try to give you the paradigm on how to use all the different features provided by ultrasound to make diagnosis. Doesn't work? Could you help me? Okay. This one is a paper on contrast-enhanced ultrasound, published in Ultrasound. And just to summarize, if you have a lesion that is fairly marginated, heterogeneously eco-appearance, and with irregular vascularization, plus stiff, you have to take into account the malignant one. Between the benign, how to discriminate? Sometimes they are assembled as baseline, but pleomorphic adenoma has the acoustic posterior enhancement, mostly frequent. Sometimes happening also in Wharton, especially depending on the size. But pleomorphic adenoma is less vascularized and is stiffer than the other one. So these are the two elements that you have to take into account to make the diagnosis. Let's look some example. Vascularized SMI. Could you, yes, okay, excellent. After CUS, the lesion shows relatively intense area of vascularization. Of course, there are some cystic areas within. So, it is vascularized lesion. You can prove also by using the time intensity curve that can help you to be more objective in the evaluation. Elasto, in this case, was soft. Sharewave, soft. Wharton. MRI, higher intensity, T2, but with intense enhancement, but not too much. And secondly, the DVI. So just to summarize, vascularized, soft, and at MRI, DVI with very low ADC, after contrast, rapid wash-in. Conversely, I told you, acoustic posterior enhancement. Polylobulated, not so much vascularized lesion. Also, after CUS, showed also better here. You look here is within the lesion. Here is parenchyma, clear and objective. Elasto, intermediate value, 2, stiffer than the other one. And Sharewave, again, stiffer than the other one. Pleomorphic adenoma. Again, remember this kind of signs that can help you with ultrasound and MRI to make diagnosis. Other case, lymph nodes or pleomorphic adenoma. There are some hyperechoic area within the nodule, but let's look at vascularization. Have you seen unique pole of vascularization? No. There are some vessels, but not entering in that area that should be the hilum representation. So this helps you to discriminate if there is a lymph node or a lesion. Then, elasto, stiffer. And contrast and answer, could you please click on the video? I would like to thank you, please. Okay. Only some bubbles within. So this was a pleomorphic adenoma, proved by cytology. In conclusion, we have to use both of them to try to enhance the features that I try to give you as tips and tricks to characterize those lesions. Recommendation, still CUS is not recommended, but is an active field. I showed you baseline with the high-end equipment. I showed you color Doppler. I showed you SMI, 3D SMI, then Micropure, then Elasto, then CUS. At the end, we have to do what we call it as first multi-parametric ultrasound evaluation. Remember, I usually show this image on my, because I ask myself, how can be better? I have to be trained. I have to be aware of what is present in the literature, so read. Then use properly your equipment. Try to avoid artifacts. Follow the protocol that I showed you. At the end, this is a picture from Fontana, from Piazza di Spagna. And I would like to remind you that in November, I'm organizing, together with Francesco Drudi, who is present here, and other experts, Carla Serra, Mirko Donofrio, and Richard Barr, and Paul Sidu, and others will be present, Clevert and others. In Rome, November 15, 16, the weather would be warm enough. I hope not to show you the rainbow that sometimes happens in front of beautiful Colosseo. I thank, again, Wessam, Christoph, all of you for your kind attention. And we have 10, 15 minutes for questions, and then I can show you practically how to use in the daily life your Elasto. I hope that you were not annoyed. I don't know if you have the third peristaltic wave. I hope not, but I thank you for your kind attention.
Yeah, Peter. Many thanks for your exciting and very comprehensive lecture. It was fantastic. Also, your lot of literature and a lot of experience in this presentation. Thanks again. So, are there questions from the audience? For a lot of questions, I'm sure. It's such a hot topic.
None? Or
None.
Too much confused, or too much satisfied? I don't know. I don't know. We'll see later. But okay, we will start to show you practically, and then you can continue to ask if you want. So, what I usually suggest is to find the right position. It is important, because also position can influence. Remember, we are looking for stiff representation. If you ask him to do this, but forcing, his muscle will be also opposing to our maneuver. So, gently, kindly, putting him in the right way. Could you please turn up? Thanks. After that, start with your probe. You can use this one. You can use this one. Which one do you prefer? You can start this? Okay, you can start with this one. This one is the larger, not higher frequency, but can help you to find what is important. Secondly, gel. You have to cover the probe. Some of the experts are still considering that we need, especially for salivary glands, to have a fat pad, to have really a barrier between our probe, our hand, and the lesion. I suggest to cover with gel. Then you try to have the best imaging. Then axial or longitudinal. There is no universal consensus. But in general, I prefer longitudinal, because in that case, I can have the better representation also of the glands, of the lobe. Then, of course, you can start. You have the good image, no artifacts. You start with color Doppler. Then you go to SMI. I wanted to show you something. How to do what I showed you as 3D SMI. You just freeze, then sweep, and then go here. There is a button that can help you to allow to smart 3D. And then, easy, you have the representation of the vessel. So, some seconds more, but the results are quite good. And as I found very interesting also for portal vein, and also for the hepatic vein evaluation, especially if I have to discriminate thrombosis or bad Chiari or other possible pathology. Then I continue with my examination. So I'm trying to be very perpendicular. Then I start just pressing elasto. The box should be adjusted, I told you. Just be upward, below, then you start your examination. Look, there are already some artifacts. Carotid artery pulsation. He is very, very excited, so please, calm down, calm down. Okay, now I'm starting. I start, I do. You know, I try to be very consistent, and then at the end, when I find the right representation, now, look, here, very artificed, too much artifacts here. So I would never put here the ROI, because otherwise this would be influenced. But look here now, you have the possibility to put your ROI. In general, I put where is more represented, avoiding the vessel, because sometimes also the vessel can create a problem. So I put one ROI and the second one. Mostly same level, although in literature have been proved that there are not so many differences. It depends on the artifacts. If there are no artifacts, you can choose different level. Then you have the number, you look at the number, and you put your number in your report. You continue, share wave. Press the button, again, you put here, then you install set. Can we show the 4 representation? Quad view. You have the quad view. Now, what can this machine allow you to do? You have the representation of B mode and any other. Now, you can put the ROI where? Where I told you. Avoiding the vessel, avoiding the artifacts, where the lines are more parallel. So, for instance, here, look at the number, expressed in kilopascal and expressed in meter per second. There is no consensus about it. In general, we start with the kilopascal. Now we are moving to MS. We will see. Still, we have to need to work on it. So I showed you what we can do with all the different, but still, there is something else. I told you micropure. So you put micropure, and then you look for possible calcification. There is a vessel here, look. And in the vessel here, there is a very, very tiny calcification, very nicely and precisely depicted. So also in a normal patient, you can find something to show how to use a different software. If someone of you wants to try, I can help you to try and to do. Who wants? Don't be shy, don't be shy. Okay, or better, do you have any other possible question for me? May I satisfy some curiosity? Because we have 2 minutes. Still 2 minutes. Calm down. 119, 118, I'm sorry. I'm joking, I'm kidding. But I like the scheme in 007 or in Austin Powers when Dr. Evil is saying, calming down. Any questions, doubts? Okay, yes. Yeah. I suggest not to use elasto. Okay, honestly, if you have a worrisome lesion, but very, very worrisome lesion, elasto is an additional tool. You use, but considering that can give you some false positive results. If you have a lesion that is completely cystic, and or grossly calcified, I don't suggest, don't recommend to do elasto. Totally agree with you. Never do it. Otherwise, you can have false positive results. Or you can do, or false negative. Depends, of course.
Yeah, a question for you regarding the vascularity of these neoplasms. Like if it's highly vascular, how do you differentiate? Because thyroid anyway is a vascular organ. So can we like confidently say that the vascularity is abnormal or not?
Yeah, that's the reason, because we are not including in our evaluation. So we don't suggest to aspirate a nodule according to the vascularization. But we suggest to use vascularization for salivary glands, because salivary glands is less vascularized, and if something is very vascularized, you can depict. For thyroid, totally right, In 2010, I published a paper, and I was the first one to come against the use of color Doppler to predict the malignancy. Right now, there are 100 papers confirming that. Yeah, it's just confusing. You know why? No, but I'm using why. Because if the lesion is hypervascularized, I don't suggest to do fine needle aspiration. Usually, our endocrinologists suggest to use thyrotropin to reduce the vascularization, and then they do fine needle aspiration. In that case, you can save some false negative results. So, you know, not useful for predicting malignancy. Useful in general, especially also when, if you do the mini-invasive treatment. In Latina, one of my previous residents now is a very good interventional radiologist. He does a lot of radiofrequency ablation and laser ablation. They found very useful to use CUS before and after to predict the outcome. And the endocrinology now have a weapon to say to them, we have treated or not treated, instead of medical nuclear scintigraphy that is reducing has a number of possibility of the request. Other question? I hope to satisfy, I have satisfied your question.
Hi, thank you for the lovely presentation. I was wondering which of all these improvements has actually helped you reduce your biopsy rate, because that's really what's killing us at the moment.
We reduced it by 10%. Right now, when we saw a lesion that was really not worrisome, although it was more than 2 centimeters, because, okay, according to the society guidelines, if you follow the European, if you have a lesion more than 2 centimeters, you have to aspirate. The American one stated 1.5, others 1 centimeter. Honestly, to now, we are evaluating, since we published the data about the growth at interval and the correlation with the malignancy, if the lesion does not show any suspicious features, really suspicious features, we don't aspirate. For instance, the TIDAS 3A, I showed, but we published 3 papers. To now, we saw that among 1,000 of cases, so 1,000 cases that we have done right now with the 3A, we saved more than 90% from the operation. Because we achieved 90% of sensitivity by using Elasto. Still, we are working on it to try to reduce even more. But we reduce it by, for instance, at least 10% for sure. Of course, we have to try, the surgeon should trust us, and also the patient. But if you explain that in the worst scenario, also postdating the operation, the outcome will not be accurately and too much affected, the patient accept. You know what? Because we are using also the worrisome sign. If I found, okay, according to the American guidelines, if you have a worrisome lesion, TIDAS 5, but less than 8 millimeter, they don't recommend to operate. They recommend strict follow-up. But in those cases, if I see that there is an increasement in size, I suggest operation, although if it is 5 millimeter, or if you have lymph nodes, or if you have other signs, if the lesion is located nearby the trachea, in that case changes. We suggest operation also if they are very small, because unfortunately, these are the cases that may be very aggressive. In general, thyroid carcinoma is not aggressive, but 5% of them can be. So what is the real issue that we have to address is to find a way, putting together all the technologies that we have right now and thinking the improvement we need, and we hope that some more new one will come out very soon to reduce those number of patients that we have not to miss.
And for the intermediate ones, which you don't aspirate?
We follow up.
Yeah, what's the interval you use for follow-up?
It depends. If they are classified as TIDAS 2 and 3, 1 year. If they are 4, it depends on the classification, of course. Okay, indeterminate, 6 months or 12 months, depending also on the size. If it is more than 1 centimeter, 6 months. If it is less than 1 centimeter, 12 months.
Thank you.
You're welcome. Prego.
Some more questions? Oh, yeah, here.
Thank you for your presentation. My question would be if you find two lesions in a thyroid lobe, one being not very suspicious, the other one more suspicious, do you apply separately for each lesion all these?
Yes.
Even if they are close
I
together?
apply to both. I apply to both because sometimes, unfortunately, also the non-worrisome appearing lesion can be stiff. In that case, I suggest to do fine needle aspiration. In general, what is the ideal that we are looking for? We need 3D real representation of elasto because we need to do to the whole lobe. Unfortunately, still this is the real limitation about our technique, but in general, with all imaging modalities.
Thank you.
You're welcome.